Medical nutrition therapy for pancreatitis. Acute pancreatitis is most frequently caused by alcohol abuse and gallstones. Endoscopic retrograde cholangiopancreatography (ERCP) and hyperlipidemia are also significant causes. The following mnemonic, I get smashed, may recall the causes of acute pancreatitis. The first step is those to take place within the pancreatic acinar cell, where the trypsinogen is converted into active trypsins, causing a cascade of additional digestive enzyme activation and cellular damage, as well as gland autodigestions. Damaged cell release activated enzymes into the surrounding tissues, causing the autodigestive process to continue, as well as entering systemic circulation by inflammatory mediators such as cytokines and macrophages. Hypovolemia, hyperdynamic circulation, capillary leakage, and fluid loss in third space characterize the following endoscopic retrograde cholangiopancreatography. The subsequent pancreatic vascular changes are disproportionate to the decrease in cardiac output as each anatomic lobule is supplied by a single end vessel, resulting in pancreatic ischemia and necrosis in severe or prolonged disease. Alcohol can amplify the inflammatory response alone. SIRS can cause primary organ failure early in the disease 1 to 14 days, including lungs, kidney, and liver. Persistent SIRS or SRIS combined with sepsis may cause multiple organ dysfunction syndrome (MODS). MODS usually develops 3 to 4 weeks after severe acute pancreatitis and is responsible for late deaths. From recent global survey on chronic pancreatitis, alcohol remains the most common factor linked to chronic pancreatitis. Heavy drinking and smoking are both independent risk factors for chronic pancreatitis. Pancreatitis can also be a symptom of autoimmune or genetic disorder. Meanwhile, the following mnemonic, Taiga O, may recall the causes of chronic pancreatitis. The first episode of acute pancreatitis is characterized by recruiting inflammatory cell, which is triggered by insults such as alcohol and tobacco. Repeated insult cause acute pancreatitis, activating pancreatic stellate cell and initiating pancreatic fibrogenesis, leading to chronic pancreatitis in most people. Particularly, this insult causes pancreatic histopathological changes in a large percentage of people, with the majority remaining asymptomatic and a few developing clinical disease. Some organ complications are biliary obstruction, duodenal obstruction, portal vein thrombosis, vascular aneurysm, and bleeding. Pseudocysts may form during disease, causing additional symptoms. Increased ductal and/or neuroplastic changes are two possible causes of chronic pancreatitis pain. Hypertrophy and nerve dystrophy are seen in the pancreatic resection of a patient with chronic pancreatitis, surrounded by extensive fibrotic tissue and lymphocyte infiltration. The diagnosis of acute pancreatitis includes blood tests. It is to look for elevated levels of amylase and lipase. Next, the diagnosis of chronic pancreatitis includes laboratory tests, imaging tests, and biopsy. Laboratory tests, which is the stool test, to measure the fat level that could suggest the digestive system is not absorbing nutrients adequately and pancreatic insufficiency. Imaging tests including CT scan, ultrasound, and MRI. CT scan is used to scan for gallstone and assess the extent of inflammation of the pancreas. Ultrasound is to detect gallstone and pancreas inflammation. MRI is to look for any abnormalities in the pancreas, gallbladder, and ducts. Biopsy, a procedure that involves taking a tiny sample of the pancreas tissue. The tissue sample will be then checked to be studied. The treatment of acute pancreatitis including fasting. The fasting, patient need to stop eating to give the pancreas a chance to recover. Nuts, pain medications. It helps in controlling the pain. And the last one is intravenous IV fluids to provide extra fluids to the body. If it is severe, the treatment includes endoscopic retrograde cholangiopancreatography (ERCP), the procedure to remove bile duct obstruction, gallbladder surgery if gallstones cause pancreatitis, and the last one is pancreas surgery to drain out fluid or dead or diseased tissue from the pancreas. The treatment for chronic pancreatitis including pain medicines for management of pain, pancreatic enzyme to aid the body to get enough nutrients, diet plan which is the low-fat meal plans that high amounts of nutrients, and the total pancreatectomy to remove the entire pancreas. Each type of treatment has its consequence, be it positive or negative. These are the treatments available for acute pancreatitis. For fasting, patient may face malnutrition due to oral intake deficiency. Next, pain medication usually causes nausea, which possibly due to pancreatic inflammation and the slow bowel movement. Next, intravenous IV fluids can prevent dehydration. The possible consequence of taking pain medicines in chronic pancreatitis may include constipation, nausea, vomiting, and drowsiness. Next, pancreatic enzyme may possibly cause the side effect. However, it can relieve steatorrhea symptom. Meanwhile, a suitable diet plan will help to alleviate pain as the pancreas is not overworked from digestions. Nutrition assessment are including anthropometry, biochemical data, nutrition-focused physical finding, NFPF, and food nutrition-related history, FNRH. For acute pancreatitis, the anthropometry including malnutrition and muscle mass and function decline. The biochemical data of chronic pancreatitis including a serum amylase or lipase greater than 3 times upper normal limits. Protein catabolism when nitrogen balance can be negative up to 20 to 40 gram per deciliter. Carbohydrate metabolism, which is hyperglycemia, more than 100 mg per dl. Hypertriglyceridemia is common and it contributes to elevated serum triglyceride, more than 150 mg per dl. Decreased absorption and impaired storage and utilization of nutrients. Micronutrient deficiency including vitamin B1, vitamin B2, vitamin B3, vitamin B12, vitamin C, and vitamin A, folic acid, and zinc, and also hypocalcemia. The NFPF of chronic pancreatitis include anorexia and vomiting, epigastric pain, ascites and or edema, and poor bone health. FNRH, medication, infectious disease, and metabolic causes such as hypercalcemia and hypertriglyceridemia, and decreased oral intake. The anthropometry for chronic pancreatitis including malnutrition, muscle mass and function decline, and smoking status. Pancreatitis including lipase is low parallel with amylase, the low albumin, malabsorption of lipid-soluble vitamins, exocrine pancreatic insufficiency, which is a fecal lactase level less than 200 microgram per gram feces. And last one, endocrine pancreatic insufficiency, which is the HbA1c, more than 48 millimole per mole of fasting glucose more than 7 millimole per liter. The NFPF of chronic pancreatitis include anorexia and vomiting, epigastric pain, ascites and or edema, and poor bone health. The FNRH of chronic pancreatitis include decreased food intake and physical inactivity, and also the alcohol consumptions. These are 3 common nutrition diagnoses. Altered laboratory values related to pancreatitis as evident by hyperglycemia. Malnutrition related to abdominal pain when eating related to pancreatitis as evident by unintended weight loss. Altered GI function related to pancreatitis as evident by steatorrhea. There are several objectives to be achieved which are divided into short-term and long-term. The short-term objectives are to reduce the risk of weight loss by administering 25 kcal per kilogram per day due to inadequate calorie intakes, to lower the risk of protein-calorie malnutrition due to pancreatic insufficiency and inadequate oral intake by providing 1.2 to 1.5 gram per kilogram per day of protein. And the last one is to decrease signs of stress-induced malnutrition by increasing serum levels of albumin, transferrin, and lymphocytes that reflect the inflammatory response. As for the long-term objective, there are two objectives that need to be addressed. The objectives are to provide the best nutritional support and to mitigate pain by minimizing exocrine pancreas stimulation. The nutritional strategy for acute. To best achieve those goals, it is important for acute pancreatitis patients with whole oral and enteral feeding support with IV fluids. Besides, if oral nutrition cannot be initiated within 5 to 7 days, tube feeding should be started. Once oral nutrition is started, they must be provided with easily digestible food, low-fat diet, 6 small meals, adequate protein intake, and increased calorie. Meanwhile, for chronic pancreatitis patients, provide oral diet as in acute phase. Tube feeding can be used when oral diet is inadequate or as a treatment to reduce pain. In any case, supplement them with pancreatic enzyme, fat-soluble vitamin, and also vitamin B12. Nutrition monitoring and evaluation. Energy requirement should be measured by indirect calorimetry or 25 kcal per kilogram per day may be used. The second one, protein requirement are 1.2 to 1.5 gram per kilogram per day. The third one, early enteral nutrition within 48 hours is recommended for patients with severe acute pancreatitis. Gastric or jejunal feeding is acceptable. The last one is intravenous glutamine may be considered in patients with total parenteral nutrition.